Jeff, maybe give a little bit to the audience about this phase 3 Clarify trial, the patient population, or maybe some of the objectives that we're hoping to get out of this.
So this trial is basically focused on men having high risk prostate cancer, and that can be defined by various means, whether it's clinical stage, the PSA level, but more importantly, the Gleason grade or the grade group, we call them now. So currently, most patients, I think, should undergo an extended pelvic lymph node dissection with a diagnosis of high risk disease, because lymph node involvement can be, depending on how you define high risk, or some of the higher risks that we take on, that they can have lymph node involvement 30, maybe up to 50% of the time, if you look for them. And I truly think, and a lot of my research has focused on removal of involved lymph nodes, not only for a diagnostic purpose, but even a therapeutic purpose, and delaying potential salvage therapies, whether it be radiation and or hormonal therapies.
Well, that would really be wonderful if that proves out, and I think there's growing evidence to suggest that. So, what do you think about the fact that, okay, right now, if you ordered a PSMA scan at Mayo, we in NukeMed, my team, I would be doing it, and then we would inject the patient, we'd image after about an hour. With the Propeller and Cobra trial, they're suggesting that when we go out to 4 hours, the imaging is better, meaning we identify more lesions, and showed a significant increase. And then at 24 hours, further increased our ability to see the number of lesions, the number of patients with lesions, significant both in statistical value, but also in terms of numbers. The data even suggested the plan of care might change as much as 48%, which was shocking to me. But it does change the workflow of the patients. In other words, now you have to do the image the day after, so it's a 2-day workflow for radiology. Do you see any impact, plus or minus, for patients in that, or do you think that's not going to be a big factor?
I don't think it's going to be a big factor when it comes to the potential gain for this. I think patients are going to be willing to stick around an extra day. With the timing of a diagnosis of even high risk disease to surgery, it's not something we do within a week, within 2 weeks. Sometimes it even can be a couple months. And we know from various data that patients can safely use that period of time, even to heal up after the biopsy, to get their surgery at a later time, or to get their radiation. Obviously, this is a surgical treated trial because it's looking at the gold standard of histopathology, which is the lymph nodes, but also the primary. And even though it's not a focus of this particular study, more and more research is coming out regarding not only the lymph nodes or potentially other sites of metastasis, but actually the primary tumor itself. Determining the looking at the MRI, looking at the PSMA avidity within the gland, as we sort of are evolving to some focal therapies to ensure there may not be contralateral disease, where focal therapy's been typically limited to like unilateral disease or quadrant only, or a small portion of the prostate. So a lot of potential other use of PSMA PET scan as we evolve over the next couple of years.
Really fascinating options that come with a better negative predictive value for METs, plus the options for more selective surgery. I didn't even know about that. That's cool. I got on the flip side of that. Maybe the last thing to discuss, Jeff, would be, what do you think about when we find distant lesions? Now, I know we've talked about, distant fake out lesions when everyone was learning about PSMA. I think you threw me a case with a solitary, tiny rib faint lesion on a tumor board that we were broadcasting, and luckily we were on top of that. But as we go forward and we get this path correlation, how often do you think it's going to really benefit the care of the patients when we find that oddball that we think is a distant met?
Well, there are various ways to handle it. I mean,
Yeah.
I think if it's amenable to a biopsy, a lot of our providers, including medical oncologists, will want some sort of tissue confirmation, benign
Hmm.
or positive. But there are some spots that are difficult to biopsy. Ribs are difficult to biopsy, as you know.
Yeah. Yeah.
And obviously the CT correlates don't always, give us the answer we're looking for. A lot of it has to do with mindset, in terms of,
Hmm.
are you willing to do surgery or provide radiation to patients that may have what we term now oligometastatic disease? Just various
Hmm.
definitions that I won't get into. I certainly think there's some benefit because prior to PSMA PET scans, we did radiation surgery, and a lot of these patients do quite well with just one modality. But certainly there's a group of patients that will develop a PSA recurrence, and the hope is that we prevent some of those potential PSA recurrences by intervening earlier. And the PSMA scan does open that window to allow us to investigate further oligometastatic treatments. And the various forms of treatments, it also depends on the anatomic site and so
Hmm.
forth. But it depends. So like every case is different, and it's very personalized. And even in the last iteration or the upcoming iteration of the NCCN guidelines, we do have a section now on oligometastatic intervention for prostate cancer.
Yeah. Yeah. It's about time. I'm glad to see that that's coming. Thanks again for joining me in the discussion. It's fun to kind of share the thoughts as we go through trying to launch these trials out with other physicians. And I don't know if there's anything else you want to add, thoughts about the trial or about the area.
I'm excited about it.
Mm.
Especially in a center that has a long history of treating high risk disease,
Hmm.
dating back for decades. When the rest of the country believed that we should not treat higher risk disease, we should
Hmm.
only treat lower risk disease, and now the pendulum has certainly swung, where we don't treat low risk disease now, other than active
Right.
surveillance, and
Right.
we tend to maybe throw the kitchen sink, maybe an idiom I don't really want to use, but certainly it's something that we know that by intervening on higher risk disease, we probably have a better chance of providing a survival benefit,
Okay.
certainly as opposed to lower risk disease. Well, will PSMA scans be part of the sort of surveillance algorithm that we use in the future as the technology improves, which will inevitably happen, in my opinion, and maybe
I
as we
agree.
start co-registering, the PSMA with MRIs, and we could even potentially eliminate or augment, what we call surveillance biopsies for men based on that sort of technology.
Very cool. Well, thanks for your time, buddy. Good to see you.
Good to see you, Jeff, as usual.